welcome to this session for RSNA Online. So the session title is Genitourinary Case-Based Multidisciplinary Review. This is part of the BOOST series, and the title is MSRO32. I'm Tristan Barrett. I'm a radiologist from the University of Cambridge in the UK. I'm an academic radiologist. My research interest is prostate cancer. On the clinical side, I do body imaging in general, but particularly uroradiology. We're just going to go around the panel for introductions. If I hand over to Nicole next.
Hi, everyone. My name is Nicole Kirchie. I'm an abdominal radiologist at the University of Michigan.
And Bob.
Hi, everyone. I'm Bob Dess. I'm a radiation oncologist at University of Michigan. I treat with patients both with external beam radiation therapy as well as brachytherapy.
And on to Arvin.
Thank you. My name is Arvin George. I'm a urologic oncologist at the University of.
So we'll move on to the cases. So if we go to case one, I'll just briefly give you the history for this. So this is a 56-year-old man with PSA level of 10.2 nanograms per mil and a previous negative transrectal ultrasound guided biopsy, that's a systematic biopsy, 1 year prior to the current MRI. So I'll hand over to Nicole to talk through the imaging from this case to start with.
Okay, so on this patient's MRI, we have axial T2 weighted image on the screen left and the high B value diffusion weighted images on screen right. And I will direct your attention to the left posterior lateral peripheral zone where there's some hypointense T2 signal that appears to impede diffusion on the high B value images. So we confirm the impeded diffusion on the ADC, and there is enhancement on the DCE, and there's a possible capsular bulge on that side also. So that brings us to the audience response question. And I'll ask the audience, how would you score this according to PIRADS, this lesion? And I'll let you think about that for a few seconds. There are probably two possible right answers here, depending on how much you believe that there may be neurovascular bundle involvement. So if you answered PIRADS 5, that would be acceptable if you thought that there was indeed neurovascular bundle involvement. I myself would give this a score of PIRADS 4 because I'm suspicious that there may be neurovascular bundle involvement, but I'm not 100% sold on these images. So that brings us to our question for the panel.
So Nicole, you mentioned, it's interesting, you say impeded diffusion rather than restricted diffusion. I think from a physics point of view, that's more correct, but most people use the term restricted diffusion. Is there a reason you use impeded?
No, that's sort of the lingo at the University of Michigan. Mm-hmm. I think I have to credit Matt Davenport for coining that term for me.
From me the way. Physicists, I think that's a more exact term and correct term to use, although in the radiology community, often we use restricted diffusion. The other thing that I was going to say, you mentioned the neurovascular bundle involvement. Are there particular things that you might look for in terms of determining that?
Definitely. So the most specific sign would be abnormal signal outside of the prostate that is in the territory of the neurovascular bundle. Mm-hmm. Sometimes you can see actual impeded diffusion involving the bundle, and that's the most specific sign. But other potential signs of neurovascular bundle involvement, like we have in this case, are a bulge or a long distance of contact with the edge of the prostate.
Okay, we'll go on to the questions for, this is an audience question. I mean, I guess we've covered that. This is an audience response question. So it's a little bit equivocal, and sometimes we put that in our reports that we're not sure. And often, actually, I find it depends on what the pathology comes back in. If this is a particularly high-grade tumor, then your suspicion levels would be raised. Obviously, if you're interpreting the MRI at the time of not having the pathology, then that's something that could be revisited once the biopsy has been done. And then these are the various questions we're thinking to pose the panel. So Nicole, you want to try and go through those with our panelists?
Sure. So this, I think this question comes up fairly often when we're encountering these questions. And the question is, how does definite involvement of the neurovascular bundle versus possible involvement affect the treatment decisions? Oftentimes we're not too sure, and we sort of are unsure whether we should say definite or possible, but does that even make a difference when it comes to treatment planning?
So what I would say from a urology perspective or a surgical perspective, there are essentially two different options for treatment here, depending on what the biopsy showed us. So if the patient was a candidate for an ablative procedure, such as cryotherapy or high-intensity focused ultrasound ablation, the presence of extracapsular extension, in my view, would potentially essentially rule this patient out from any ablative option. So definite versus possible does make a big difference here. In terms of if it was possible, then I would lean towards a cryotherapy option where I could ensure that I get a good freeze outside. And if there was no involvement at all, there was no suspicion, then it would be potentially there would be an option for high intensity focused ultrasound ablation. From a surgical perspective, it defines our ability to do a nerve preservation on that side. So given the fact that the positive predictive values for ECE are relatively low, that I would want to ensure that if there was definite involvement, then I would not preserve the neurovascular bundle. If it was possible, that determination would be made intraoperatively based on how well the tissue planes separate, with a low threshold to be able to go wider on the left side and be more aggressive for a nerve sparing on the right side.
Arvind, do you have any experience with using, I think it's NeuroSafe, where you do a frozen section intraoperatively to try and get histology back to see if there's evidence of extracapsular extension, or do you know any colleagues that use that technique?
No, I don't. I don't know of anybody who specifically uses that technique. So I wouldn't be able to speak to that.
And I guess the third and the fourth question there are really sort of saying, well, if we're away from the 5 o'clock, 7 o'clock region where we know the neurovascular bundle is close, and we're equivocating whether there's early extracapsular extension, does that, from a surgery point of view, affect how you approach things, or are you're more able to give wider margins there, so it's less of a concern?
Yeah, I think anteriorly you can always get a wide margin, so I think it becomes a moot point. And I think what you had mentioned before is really important. What's the grade of the tumor? What's the volume of disease that we see there? That's going to speak to the likelihood of extracapsular extension. Again, because the positive predictive value is relatively low when we encompass all the terminology that's used, whether it be focal bulge, capsular contact, or tumor contact length, unless we get a really strong kind of opinion from our radiology colleagues, we would. I don't think that it would necessarily change our treatment plan, at least from a surgery perspective.
And Bob, do any of these different factors come into play when you're thinking about radiation therapy? Do you give?
They do. Some overlap with Dr. George, and some are a bit unique to radiation therapy. So, first of all, the overall clinical management of definitive radiation therapy, whether that's brachytherapy-based, external beam, or both, the decisions to add hormone therapy to radiation therapy are largely going to be delivered based upon the Gleason score here. So the possible versus early versus neurovascular bundle involvement, whether or not you're adding hormone therapy to that treatment is largely going to be based off of the Gleason score, not so much based off of how confident we are in the neurovascular bundle involvement. But similar to Dr. George, if I do see extensive disease that's outside of the prostate that may lead me to perhaps be less inclined to offer brachytherapy to that patient and more inclined to offer external beam. And then the final thing that I think my practice overlaps with Dr. George because he does a lot of these procedures, but one a bit of pause that I have is often, especially with external beam and SBRT to the prostate, now we're often using, at least in the United States, hydrogel spacers to give space between the rectum and the prostate. And if there is anterior ECE or early ECE, that doesn't cause much of a problem at all. But posterior disease, gives us pause to offer or want to place a rectal spacer based off of, if nothing else, the theoretical risks of having that spacer be involved with the tumor.
And your decision to use the spacer, is that based on the location of the tumor, or is that just a general thing to try and protect the rectal? Well,
it's become, especially with more favorable risk cancers that are unfavorable enough to treat. Spacers becoming more and more common in our practice. Dr. George does all kinds of them for us, and the clear-cut candidates are the ones that have no posterior extent. In my mind, the clear-cut candidates that are not candidates are the ones that clearly have posterior ECE. It's the bulge, it's the touching posterior where it's a judgment call based off of, like Dr. George said, the volume or the total tumor extent and the grade of the cancer.
Mm-hmm. And if I can ask a question to Dr. Barrett and Dr. Kirchie, oftentimes or all the time, the hydrogel spacer is supposed to be placed between Denonvier's fascia and the rectum, so essentially in the prerectal fat. How often can you see whether invasion extends into Denonvier's, or is that even possible for you to be able to make that interpretation?
I think generally these are pretty straightforward. I think for me, although I'm just starting to get more and more comfortable with them and more experience with them because it's not something that we've used for many years yet. But I have definitely seen cases where it's possible, unfortunately, for the gel to infiltrate in areas where it's not supposed to go. And I think that when you see that, you definitely see that. So I think it's fairly straightforward. I don't know, Tristan, in your experience, have you had any more difficulties?
So I don't have a huge amount of experience. It's not typically reimbursed in the UK. So I've seen maybe in the order of 15 to 20 cases of spacers. And usually when they're done, you do imaging just to make sure everything's in the right place. I mean, I have seen sort of case reports and people describing it dissecting through rectal wall and being in the wrong place, but from my limited experience with them, maybe that's just our surgeons, how they're able to place them, that they've all been very easily visualized and in the correct anatomical space. So 52-year-old man, rising PSA levels, currently 11.53, and has Gleason 3+3 disease on biopsy, but also with a focus of central necrosis and intraductal cancer. So this is the subsequent MR imaging. And Nicole, if you want to start talking through that for us.
Sure. Again, we have the axial T2 weighted image on the screen left and the high B-value diffusion weighted image on screen right. And throughout the peripheral zone, in this case, you could see that there's some sort of intermediate hypodense T2 signal, and it's all associated with some impeded diffusion, although it seems overall pretty mild, both the degree of T2 hypointensity and the degree of impeded diffusion. Maybe there's a little bit more in the left posterior neurovascular bundle, but in this, just from these first two images, as I look at this case, the first thought that crosses my mind is that, this is a post-biopsy image. So could this be diffuse prostatitis that I'm seeing, or could this be diffuse hemorrhage? So we'll look at some other sequences, I think, to tease that out a little bit more. And as we scroll more caudally through the gland, we can see similar findings. There's mild impeded diffusion throughout the peripheral zone. When we look at the ADC map, we see that there is some hypointense signal there, but not very convincingly impeding diffusion, just sort of mild. So again, this kind of plays into the picture of maybe prostatitis, maybe hemorrhage. I think we have some more images that'll help us. So here we have the apex of the gland, and we can see nearly encircling the urethra in the center of the prostate is a band of hypointense signal on the ADC map and high signal on the high B value images. So that is definitely suspicious, much more suspicious than the signal that we were seeing in the peripheral zone throughout the rest of the gland. And this could be a potential blind spot. Oftentimes when we're reading these cases and we get to the apex, the anatomy is a little bit more confusing. There's a little bit more going on, and it could be easy to overlook little slivers of abnormal signal like this.
And we didn't say the type of biopsy, actually, but I'm assuming that this was sort of a randomized transrectal biopsy. So at this level, we're quite low down in the apex. So it's
correct. This is an easy spot to miss.
Yeah, so that we may well not have sampled that with a systematic biopsy. The other thing that I mean, I guess we see this increasingly. This is quite a young patient, a 52-year-old. And yes, they can have prostatitis. I see this quite a lot. We almost describe it colloquially here as being a dirty peripheral zone that you see in these younger patients. And the feeling is, from talking to colleagues, this might just represent quite a glandular peripheral zone, age-appropriate glandular peripheral zone that is just a lot more cellular than we're used to seeing in, our traditional, if you like, patient population of 60 to 75 years old, where you have simple atrophy plus or minus cystic atrophy, which with a relative fluid component, which then looks high signal on the T2 weighted imaging. And also with that sort of cellular appearance to the peripheral zone, you tend to have mild restricted impeded diffusion and often some early enhancement on the DC as well, which makes it a very difficult gland to interpret, and on that background to exclude something more significant underlying. I don't know if that's your experience as well in the younger patients. Definitely,
absolutely. Some of these cases are some of the most challenging, I feel, to evaluate for all of us, our trainees, and those of us that are more experienced with them. It's a struggle, and you always sort of second guess yourself a little bit to say, am I missing something here? Is this masking something in the midst of all this signal? So they're definitely tricky and definitely much more common in younger patients, unfortunately.
Okay, so we'll come on to the sort of the end of the case. I mean, you've alluded to this. Maybe you want to just talk through.
Sure. So this patient actually went straight to prostatectomy after his biopsy. That focus of intraductal cancer was concerning. And the lesion that I pointed out to you that you could see again on the ADC map on the screen right, that hypointense ADC signal there, that restricted diffusion actually corresponded to a site of Gleason 9 prostate cancer. And that was the only site of Gleason 9 cancer in the gland, was this area around the membranous urethra. You can see from the whole mount histology on screen left, the same area has been demarcated of where the cancer is, and that corresponds to pretty much almost exactly to the area where we see the abnormal signal on the scan. So this is not prospectively recognized. This did fall into a missed lesion on the MRI, and this proved to be pretty challenging when the case went to the OR for the dissection of this area.
I mean, I think we can always learn from these cases, can't we? And I think it's always useful as a radiologist to try and follow up, pathology, be that from biopsy, targeted biopsy, or from prostatectomy, particularly if it shows up something unexpected. So if we call a negative MR and systematic biopsy comes back with anything from Gleason 7 and above, or if we call a high probability lesion, particularly the PIRADS 5, and targeted biopsy comes back negative. Now, it might be that it's the biopsy, an issue with the biopsy and sampling. It might be that if it's negative, it's not completely normal. So, for instance, quite chronic inflammation, or in some cases, granulomatous prostatitis, but enough to explain the imaging findings. But I think when there's a discrepancy in the radiology and pathology, it is worth re-reviewing those cases and see if there's any learning points to improve practice.
Definitely, that's really the best way to hone your skills and to have safer patient outcomes in the future is to meticulously follow up and see what your pathology results are. So,
panel question. So I guess the treatment decision was already made in this case. It wasn't picked up prospectively, and the patient went on to surgery. But the questions are really sort of in and around membranous urethral involvement. How does that potentially affect the patient treatment options? And again, similar to the last case, if we're equivocating about it and we say it's possible, does that have an effect as well?
So I would say from a surgical perspective, anything that's at the distal apex is a challenge not for any treatment option, whether that be an ablative treatment option, surgical treatment option. And I'll let Dr. Des speak to it from a radiation oncology perspective, but I think that it's a challenge there as well. The issue from a surgical perspective is that it makes it challenging to be able to preserve a long urethral stump. And the longer the urethral stump you're able to preserve, the better the continence outcomes in terms of return of early continence. And also, if you have to actually cut into the membranous urethra, then you're essentially going to be affecting the sphincteric complex, the external urethral sphincter, which will have significant impacts in terms of continence. Now, I will say that from an ablative perspective, for me, these aren't really great candidates because they're inherently very challenging to treat. I will make a note and from a diagnostic perspective, that this is also really challenging. Like both of you mentioned before, at the distal apex, this is something that's almost never sampled. And if you look at it, it's so close to the urethra that essentially any biopsy that would be taken would actually end up having to traverse the urethra, which we try to avoid. One, because it's painful. And second, because the risk of traversing the urinary tract means that you can potentially seed it with urinary organisms if the patient has a positive culture or urinalysis or colonized, even if they're not symptomatic. Potentially a transperineal approach would allow you to come parallel to the urethra and avoid it. But in the US and the UK, I think that it's growing in popularity, but it's still a small proportion of overall biopsies that are performed transperineally.
And Arvind, you mentioned so that's obviously if we're suggesting involvement around that area. Let's say you had a lesion remote from that. Is the membranous urethral length something you look at preoperatively to determine, fitness for surgery or risk of incontinence post-surgery?
Yeah, I think so. I think that the larger, really when it's 1 centimeter or greater, that's been associated with better early continence outcomes. So I know that there is some mixed data in terms of supporting it, but as a general rule, it does help with patient counseling preoperatively to manage expectations regarding return of early continence.
And Bob, have you got input from radiation oncology on cases like this?
Yeah, there is some similarities again to Dr. George. So from a brachytherapy perspective, it's technically challenging to place, whether you're doing LDR, to place seeds very near the urethra, and even HDR, high dose rate brachytherapy, which I do. It's more challenging and I tend to try to avoid it in cases with clear involvement of the membranous urethra. And then as Dr. George was pointing out, the distal disease isn't so much as a challenge for the external beam radiation in general. It's just you have to be very mindful of your contouring and your treatment volumes to make sure that you're properly defining the disease at the apex. And, we do our best to register the MRIs that are done, whether it's a simulation or a diagnostic MRI, and use that information and all of the sort of findings from the report that you guys provide to us to try and make sure that we don't miss disease, particularly at the apex.
Mm-hmm. Okay, so that was so our first two cases. The broad theme there really was the local staging of the gland, the T staging, which is one of the crucial components of the MRI report. So as well as detecting lesions, identifying them, we also need to particularly give information on T staging. And sometimes, as was alluded to earlier, we're not so accurate with that. Certainly our specificity is higher than our sensitivity. And that's true for T3A disease and T3B disease. The sensitivity for each is around 50%, but the specificity tends to be quite high when we do call it at around 90%. So that's sort of a room for improvement. And it is an area where we do equivocate on for good reason because of that, because we're aware of that poor sensitivity. So that was the sort of the theme with the first two cases. So we'll move on to case 3 now. So I'll just quickly go through the history of this. So this is a 60-year-old man recently being diagnosed with what we consider low volume, low grade Gleason 6 cancer, and is considering whether active surveillance is the most appropriate management step.
Sure. So we have the axial T2 weighted image on screen left and the high B value diffusion weighted images on screen right. And on the T2 weighted images, again, you could see some intermediate hypointense T2 signal throughout the peripheral zone. There's maybe an area in the left posterior lateral peripheral zone, sort of a lens-shaped area that looks a little darker on that T2 weighted image than the background. When we look at the corresponding area on the high B value images, we see that there is a focus of impeded diffusion there, and not much going on elsewhere throughout the gland. If we take a look at some more images, I think we could try to tease out what's happening here. So if we look at the ADC map in that same area where there's maybe that little bit of darker T2 signal in the peripheral zone on the left, we see some corresponding dark signal on the ADC map. So this area is pretty strongly impeding diffusion. So what's going on in the rest of the peripheral zone? If we look at the T1 images, we'll have our answer. So this patient was post-biopsy, and the rest of that signal throughout the peripheral zone is hemorrhage. But again, on the T1 images, you can see there's sort of an elliptical shape in the left posterior lateral peripheral zone over there, where we have the impeded diffusion. And that is an area of hemorrhagic sparing. So that's suspicious. And this area did enhance on the post-contrast images. So that's something I would consider a PIRADS 4 observation.
So you preempted the question there.
Sorry.
In Michigan, do you do MR pre-biopsy, or is that increasing in your practice?
We do. We do them for all sorts of indications now. So we do them pre-biopsy. We do them post-biopsy. We do them for surgical planning. We'll do them for active surveillance. We do them at each stage. And it's definitely a little bit more challenging when you have hemorrhage throughout the peripheral zone like this. It could definitely potentially obscure some lesions, as we kind of talked about in the case prior. But sometimes it helps you a little bit, like this case, if you have an area that is masked out by that hemorrhage, it could be helpful.
Yeah, the hemorrhage exclusion sign, although you don't necessarily want to have to rely on that.
Correct.
As the only means. How long do you typically advise to wait post-biopsy before imaging in patients that have had a previous biopsy?
We typically wait about 6 weeks or so. I don't know. I think this practice varies a little bit throughout the country. I know some places don't wait at all, and some places wait at least 6 weeks or maybe more. But I think from my experience, 6 weeks seems to be about the sweet spot.
There is some data from a few years ago from a series that they did in London at UCL, where they imaged patients before biopsy and then at different intervals, 3 monthly up to a year post biopsy. And in individuals, the hemorrhage on T1 can persist for a number of months. But even when that's dissipated, you still can see some residual changes on the T2. Luckily, the diffusion weighted imaging doesn't tend to be as affected, so you can rely on that a bit more than the T2 and potentially DCE. DCE can be problematic if there's already high signal pre-contrast, but you can use subtraction techniques sometimes to try and see enhancement. But yeah, challenging when you have a lot of hemorrhage around. So I guess the point around this was whenever we do an MR in this context where we have that history, one question we're asking, as I said with the previous cases, is what's the staging of the gland? So particularly the T stage of the gland. And really the sort of the secondary question we have to then ask and answer is, given the fact that we've had a systematic biopsy, and if we think back to case 2, we know we can miss significant disease. So do we think when we review this MR that there is a significant lesion elsewhere in the gland that may have been missed by the systematic biopsy? So either the extreme apex or the anterior gland, or even posterior in the peripheral zone that just by sampling error may have been undersampled or missed. So that's a key question we have to answer. So I guess that's what the first question here is getting at, is do we think this is congruent, the MR findings are congruent with the biopsy findings, or should we do an early, ideally targeted rebiopsy of this area that we've seen? So I don't know, what are your thoughts on that, Nicole? Do you think?
That's tricky. I think in this particular case, if I recall correctly, I think we did think it was congruent. If you do think it's congruent, that could be confirmation that the patient is a candidate for active surveillance. If not, definitely the patient should have a repeat biopsy of the area. If I remember this case well enough, I believe the previously discovered prostate cancer was congruent with this observation. So this particular patient, if I remember right, did go on to active surveillance.
Arvind, do you run active surveillance clinics? What is your follow-up for the patients in terms of intensity and imaging or?
Yeah, so we've kind of, not just at our own institution, but within the state of Michigan, we've embraced the concept of confirmatory testing in men who are considered potential candidates for surveillance. And that confirmatory testing ideally will be employed within the first 6 months of their diagnosis of either low risk or favorable intermediate risk prostate cancer. And that can include either an MRI, a repeat biopsy, or a genomic classifier, which can provide some additional information regarding the genomic potential of that specific tumor. If I'm talking specifically about MRI, the reality is that most times we can never confidently say that the area that was sampled is concordant with the area that was visualized on biopsy, even if they're labeled to be within the same sextant, because of varying practice patterns with biopsy technique. Even though it may be a right mid lesion and the right mid lateral biopsy was positive, you don't know if you glance the edge of it, whether you sampled it through the middle of the lesion. And so in general, in my own personal practice, I would recommend what we call a confirmatory fusion biopsy. And then based on that information, the patient would be deemed a candidate for surveillance or not. And then understanding what the pretest positive predictive value of a PIRADS4 lesion is, being essentially 30 to 40% having Gleason 7 or above, I would want to make that determination first before ultimately employing active surveillance as a strategy for that patient. And then the surveillance strategy is usually a PSA every 6 to 12 months, an MRI every 12 to 18 months, and a biopsy every 1 to 3 years. The intervals being determined by prostate exam changes, PSA changes, and MRI imaging changes.
And would you take on patients that have any 4 components, even if it's a minor 4 component, or do they have to be Gleason 6?
So even patients who had a small amount of pattern fall, if they fell underneath the criteria of the favorable intermediate risk on NCCN guidelines, I think that we would offer that to the patient. However, it would be a discussion regarding understanding what is the risk of metastasis versus prostate cancer death versus progression if they are starting with Gleason 7 versus starting with Gleason.
Yeah, so in our institution, a similar thing. We have we typically ask the pathologist to quantify the percentage of grade 4 within the samples. Admittedly, not always easy from a biopsy specimen alone. But if it's less than 10% or possibly up to 20%, then they can be candidates for active surveillance. I think overall in our active surveillance population, about 85% have Gleason 3+3 disease, and around 15% have 3 plus a minor 4 components. And our follow-up tends to be based on a risk stratification of prognosis of progression being sort of low or intermediate or high risk, and that's particularly based on the Gleason grade, the percentage of the cause involved, if an MR lesion is present or not. The lack of an MR lesion is a very good prognostic indicator typically, and also the PSA and the PSA density. And depending on which they fall into, they might get yearly MRI or 18-monthly MRI, or the very low risk group only get 3 yearly MRIs. And often biopsy is triggered particularly by imaging changes rather than, or if there's a significant PSA change rather than at mandated intervals. But I think this is something that's evolving, and lots of different centers have different ways of running the programs, and it's something we're learning about all the time. Let's go on to the next case. So I'll just briefly give you the history here. So you can see, and it will become apparent that I've redacted some of the history there. But this is a 67-year-old man, biopsy naive, PSA 9.6. So hopefully everyone can see me scrolling through now some MR images. So the first thing to note here, it looks a little bit strange on the T2 axial imaging up here. So we've got bladder, we've got seminal vesicles. Seminal vesicles are coming down towards the midline posteriorly here. And the reason for that is that something else is missing. The rectum is missing. So that was the redacted bit of history I put in there till I showed you this, is that this is a patient that has a history of ulcerative colitis and has had an AP resection previously. And this is typically the appearance we see, that within that space, the seminal vesicles fall posteriorly in the midline. Now, this is challenging from a workup point of view, because obviously without a rectum in situ, the patient can't have a digital rectal examination and also can't have a transrectal ultrasound guided biopsy. Now, you might think you could do a transperineal biopsy for those that are aware of that as a technique, but typically in order to do that, you still need a rectal probe in situ. You have an ultrasound within the rectum that is guiding the needles as they come in from the transperineal entry point. So either of those biopsy routes then become very challenging. So these are always difficult patients to work up. So within this MR, and I'm hovering over this area here, the diffusion weighted imaging really helps us here. So high signal on the B-value imaging and corresponding low signal on the ADC map. And you can see this early enhancement on the DCE. Okay, so that's an area of interest to us. This is an area we've picked up. And that's the appearances you typically see post-AP resection. So you can play along at home if you like. So these are the key images that we've highlighted. So early enhancement on DCE, low signal on the ADC map, and there is some low signal there, wedge-shaped, yes, but corresponding restricted diffusion. So do you think this is PIRADS 1, 2, 3, 4, or 5? So based on size, this would be PIRADS 4. If we think there's extracapsular extension, then we might call it PIRADS 5. I don't think there is in this case. The invasive behavior that qualifies for a PIRADS 5, even for lesions less than 15 millimeters, is a slightly interesting concept. It doesn't just mean extracapsular extension T3A disease. It could also mean seminal vesicle involvement, T3B disease. And it can also mean going from peripheral zone into the transition zone, even if it's away from the capsule, or vice versa, from transition zone into the peripheral zone. So that's not always something, that latter one is not always something people appreciate, but that's what the terminology is deliberately said, invasive behavior, rather than specifically saying things like extracapsular extension. So we call this a PIRADS 4. I've sort of alluded to the difficulty here, and this is a bit of an open-ended question because there isn't necessarily a right answer to this. And these are all different techniques that have been reported in the literature as to how to get biopsy confirmation of the lesion. Perhaps open that up to the panelists. In your practice, what's your experience of how to get biopsy confirmation in these patients without had a previous AP resection?
So I could maybe provide some insight here. I think that the most accurate biopsy would be an MR guided biopsy. You would have real-time verification on sampling the lesion. I think the next best option would be a fusion biopsy, and that's currently what I do for these patients in my practice. It is inherently more challenging because there is a significant amount of soft tissue between the perineal skin and seeing the prostate, and it's a non-traditional view. So rather than getting a true transverse or sagittal view of the prostate, you're essentially getting a oblique coronal view and a sagittal view of the prostate. And so using software-based fusion, there is going to be a greater degree of registration error. And so I tend to oversample the area of concern to help account for that registration error. The reason why I like doing a fused biopsy is it also gives me staging information with regards to the rest of the gland. So I'm still able to complete a 12-core biopsy to understand what is the volume of disease in the rest of the prostate, essentially being able to identify sites of MR invisible disease. These procedures, I do it with an end-fire ultrasound probe. It's essentially a transrectal probe, but using the end-fire component of it. And it's done under sedation with a catheter in place which acts as a landmark for me to be able to visualize, because it can be disorienting having a different view, and the urethra basically helps normalize that.
Yeah, and as you say, so we've run into this difficulty. These come along like buses. You do 2 or 3 in a month period, and then you don't do another one for a year. On average, we probably do about 2 a year of these. We have had success more recently in doing this fused approach, but as you say, you get a coronal view and a sagittal view rather than an axial view. When you're coming from the perineum and scanning, you can't get an axial view. And that can be a problem for some of the software for the fusion software that's set up for an axial fusion. We did a lot of these, and this particular case as well, with a freehand approach. So I would join a urology colleague in theatre. I'd be scanning with an abdominal probe in the sagittal plane across the symphysis pubis, and roughly guiding the needle essentially to kind of quadrants, and near field quadrant or far field quadrant. It's not a particularly precise guidance that you can provide, because as you're scanning, the needle is coming across your ultrasound probe, so it's very difficult to see the tip of the needle. But we did get tissue in this case, and as you sort of implied, Arvind, as well, it tends to be a sort of a saturation biopsy approach to the area of concern. So this was the histology report. So Gleason 3+4, pattern 4 is around 20%. So on the borderline perhaps for active surveillance. So this is again a bit of an open question. There might not be a specific right answer to this, but these are the treatment options that might be available. Obviously, from a surgery point of view, there's been previous AP resections. There could be some scar tissue around. From a radiation oncology point of view, there's a history of ulcerative colitis that might be problematic for bowel. So perhaps I'll open it up to our 2 clinical colleagues to say what their thoughts are with that.
So, Bob, do you want to comment first on radiation,
Sure.
and then I can give some comments on surgery?
This is an evolving space, and certainly not every patient that we see gets this. But Dr. George had alluded to genomic classifiers to help with confirmatory testing. And this is a place where I think any of the options that involve treatment have toxicity or challenges that are above and beyond the normal case. And here's where you can get a better assessment of, is this Gleason 3+4 disease or grade group 2 more acting or looking genomically much more like a low risk cancer or something more than that. And that may help guide my willingness to offer treatment. And if that treatment was offered, it would likely be external beam radiation therapy rather than, any of the other options. If genomic classifiers were not available, you have to look at the rest of the health of the patient and make it a patient-centered decision. But I think active surveillance would be reasonable here too.
From a surgical perspective, with regards to robotic prostatectomy, it is technically feasible, but I think we'd have to contend with potential adhesions from his prior surgery. And then the second concern would be the placement of his stoma in a patient, either colostomy or ileostomy if the patient's had a prior total colectomy. That can determine port placement and feasibility for a robotic prostatectomy. Certainly, an open prostatectomy, which is essentially done in a retropubic approach or extraperitoneal approach, that would 100% be feasible. But oftentimes, in my experience managing these patients, oftentimes they're quite amenable to pursuing radiation if they're seeking definitive treatment.
Okay, so quite challenging. In the end, we chose active surveillance, possibly because of all those factors that you mentioned might be tricky and borderline features. So we did follow this patient up. So this is sort of the audience participation question. How would you assess the follow-up MRI? So would you use PIRADS, so the first version of PIRADS or the most recent version of PIRADS? Would you use PERSIST? Would you use PRECISE? Would you use RESIST? I'll give you a couple of minutes to think about that. One thing I'll say is for RESIST, which radiologists are very familiar with elsewhere in the body, is typically you have to have a lesion of 10 millimeters or more to be considered a target lesion. And often when it comes to prostate MR, if patients are suitable for active surveillance, they don't hit that threshold. So that might be a reason we don't use that. PERSIST is a PET-based system of following up. PIRADS, obviously, you're familiar with. PRECISE, why is that in there? Well, that's in there because that's the correct answer. So this is from a working group that came up with this back in 2016, published in 2017. It's a 5-point scale of how you assess the follow-up MR, with 3 being the default that there's been no change and no new features. Now, we're not really expecting things to get better because we're not actually treating the patients. But sometimes the lesions can become more conspicuous as background inflammatory change may disappear. And really, we're interested if it goes to 4, where we think that there's been progression in the lesion, which probably triggers a repeat biopsy, or 5, which we hope not to see, where we see definitive stage progression from a radiology point of view. So going from what would be T2 disease to T3A, T3B, T4 disease, or possibly nodal involvement. So within this case, we did follow them up with the yearly imaging. Over time, this did get bigger and more conspicuous, so bigger on the T2, more conspicuous on the diffusion-weighted imaging. So we called this PRECISE 4 over that time scale. So I guess the question now would be, was there enough evidence already from existing histology plus imaging to go straight to treatment? Or would we try and repeat biopsy with all the challenges that we've alluded to already? Well, we decided to repeat the biopsy just for absolute confirmation, and that did come out as being predominant for disease with quite a long maximum length of tumor involvement. So they're probably now meeting threshold for treatment. So again, I mean, it comes back to the same options and the pros and cons that we discussed previously on this. We decided locally to go for hormone therapy and external beam radiotherapy. And the patient has done well. They're a year down the line from that. But obviously, from a surgical point of view and from a radiation oncology point of view, these can be tricky patients to manage. Okay, let's go on to the next case. So I'll quickly give you the history here. 61-year-old man, biopsy naive, PSA 4.87. We've got the T2 weighted imaging here and then the diffusion weighted imaging along the bottom there. Now, what you can see, that there is some rectal loading here. And actually often better depicted on the T1, you can see what is fecal matter and what is air. So typically rectal loading can cause spasm, particularly if you don't use anti-peristaltic agents, and that can cause a lot of motion on the T2 weighted imaging. But air is the thing that really causes problems with the diffusion weighted imaging. So if you've got this rind of air here, as we do in this case, you can get a lot of distortion and warping susceptibility artifact affecting the diffusion weighted imaging, as we have in this case, and essentially making it not really of diagnostic value. The T2 is difficult to interpret. It's, again, one of these sort of dirty peripheral zones, if you like. There's quite heterogeneous intermediate T2 signal. There's no hemorrhage on the T1 pre-contrast. So these can be cases where the DCE really helps you out. So if we go through the contrast run here, you can see already on that first run post-contrast, there is some enhancement in the left apical peripheral zone and becoming more conspicuous again on that second contrast run. So there's some focal enhancement there on the DCE. There's not that much background enhancement. And then actually, if we go to that area on the T2 weighted imaging, knowing that that's there, despite that background, I think you can start to pick out where that area is on the T2 weighted imaging. Again, this is apical, relatively low, so a systematic biopsy may miss that, so important to pick up. So we call that as a high probability lesion. So this is a more general question in this context where, if you're familiar with the PIRAD scoring system, when we're in the peripheral zone, the diffusion weighted imaging is the dominant sequence, DCE is the second sequence, and T2 weighted imaging is all the way down in third place. So if we lose the diffusion weighted imaging, what happens? Does the DCE as the second sequence become dominant? Do we limit our assessment to staging only? Do we perform spectroscopy? Do we go straight to biopsy? Or does T2 weighted imaging become dominant? I'll give you a couple of seconds to think about that if you're playing along at home. It's a slight anomaly in the PIRAD scoring system. You would think that DCE as the secondary sequence becomes dominant, but that's not the case. It's actually T2 becomes dominant, and mainly because it's scored out of 5, as is DWI, whereas DCE is only scored yes or no. So T2 actually leapfrogs DCE in this case to become the dominant sequence, and DCE remains as the secondary sequence. We limit the exam to staging when we have no functional sequences. So if we only had the anatomical T2 weighted imaging. So in terms of the scoring of this, how would we score this? Well, it does depend partly on size, and it kind of depends whether you believe the T2 or not. So retrospectively, I pointed out that area on T2. So we might say that's a high probability lesion. It's therefore in its own right as what is the dominant sequence, a PIRAD score 4 or 5 based on size or features of extracapsular extension. Or you might say it's indeterminate and a score 3, but then the secondary sequence is positive, so it becomes 3 plus 1. So either way, you would end up with 4 with that, unless you think there's invasive features, which we might come on to, and then you would call it a PIRADS 5. So that's the sort of working how we get to the score when we don't have the diffusion weighted imaging. This might be a bit of an issue. So I've talked about that rectal loading. It can be an issue for biopsy planning, but maybe, Bob, do you want to come in on how that can affect the radiation therapy planning?
Yeah, so we definitely have bowel prep instructions that we give our patients when we're doing our CT simulations for our radiation planning, because that particularly we want that same anatomy to be consistent day to day, particularly if we're doing, say, prostate SBRT, very high doses per fraction in a short course. And more patients are getting treated with shorter and shorter fractionation. So anatomic consistency is really important. And one way to do that is to have an empty rectum. How the rectum looks at the time of MRI, we still can get a pretty good fusion and a pretty good registration to have the sort of the general anatomy of the prostate. So I think we're more focused on the sort of bowel filling consistency at the time of the CT simulation rather than the MRI.
So this was a higher grade lesion, so 90% grade 4 in all 4 cores, perineural invasion. So I guess the question is, how would you stage this? Well, locally by MR, and I think with that knowledge, I think we do call this T3A disease with that higher grade disease given the broad capsular contact. And what modalities would you do for distal staging? So perhaps an open question for the guys in Michigan. How would you stage this case? Would it be CT and bone scan? Would it be whole body MRI? Would it be PSMA PET?
Yeah, so at Michigan, for intact prostate cancer patients who have not yet received treatment, so their original diagnosis, the staging still tends to be a CT and a bone scan, plus whatever information we get with the MRI. We do have PSMA PET capabilities here, and it's growing in frequency in the recurrent setting, either post-radiation therapy or post-prostatectomy. But outside of clinical trials or outside of a circumstance where a patient already comes with their PET scan, we have not employed PSMA staging up front, which I understand may be different than other parts of the world.
So we've recently started using it in Cambridge within the last sort of year or so in the setting of biochemical recurrence based on PSA and in high-risk patients at presentation, which this patient would qualify for. And interestingly, there's a node here that's below size criteria that was lighting up on the PSMA PET. There's also some nodes here, para-aortic region, again, not enlarged by size criteria. So if we relied on that standard of care, the sort of traditional way of staging it, we would say N0, M0, but with the PSMA PET, we're now calling this N1, M1A based on non-regional nodes. So that's quite a change with the PSMA PET. So the last couple of questions as we finish off here is, does this affect the prognosis you tell your patients, and does this affect your management? Would you not perform surgery now, or do you do that as part of multimodal therapy?
I will say that this is a bit of Pandora's box. It becomes a bit challenging to decide. Lots of us change our management approach, but I'm not sure we have randomized data that guides that we're actually changing it in the right direction. Often these patients will get nodal, if it's a disease that can be encompassed within the pelvis, a lot of times they get radiation therapy to the pelvis and the primary tumor along with hormone therapy based off of, phase 2 data in the recurrent setting, where treating all of the PSMA positive disease seems to have some benefit in terms of disease-free or hormone-free outcomes. Part of what I go back to is, older data where some of this even predated the PSA era or even the bone scan and CT scan era, where we ask questions, is there a benefit of treating the lymph nodes and the prostate on top of hormone therapy? And some of the eligibility of those trials had PSAs up to 150. And there's pretty dramatic survival benefits with adding radiation therapy on top of hormone therapy for all comers in those trials. And so, of course, if they have distant disease throughout the body, maybe I would withhold the radiation therapy component. But off trial, I am hesitant to omit or not treat with radiation therapy or alter my management too much to give less radiation therapy than what I would have done had I not had a PET scan.
Yeah, I think I agree. It's difficult because these are patients we would have offered those treatment options in the past, and we don't really know the long-term effects of these micrometastatic disease that we're picking up with PSMA PET now. Okay, I think we better call it to a close there because we're about up to an hour. So thank you very much to all my panelists for taking part in this case discussion, and I hope everyone at home has enjoyed being involved in this. Okay, thank you very much. We'll call it a close now. Thanks.
Thank you.
Thank you.